empty our mind. I always say that when we look at something very complex to learn, one is simple. You have to empty our minds. Empty the minds and empty the cup. Only then we'll be able to get the information in. So for some time, become like a child. Just become like a child and go through what I'm telling you. There is nothing which I'm telling you which is from my own creation. All are evidence based. Uh, Whatever I'll tell you will be totally evidence based. So I'll give you my take that just to start with that endometriosis actually is a condition which looks at the whole uterus and ties it down. And more than that, I say that it'll light a fire inside the uterus. The whole of the pelvis of the woman keeps working. The young girls keep crying. They don't know what to do. So they are in big pain. They're in big pain, and whatever bandages we apply by taking some pentoxifylline or some painkillers doesn't give her any help. So we do quite a lot, but the women also have to conceive. So I think we keep boxing each other. But we don't reach anywhere. These are the adnexal masses which we normally see, and then they may come along with some amount of hydrosalpinx, as you can see here. So it's always a challenge and always learning. Endometriosis medical management, giving them Dinogest or Letrozole or giving them some painkillers, OC pills, GnRH antagonists. So all the options we have. But before I go to that, I will just go to pathogenesis, prevalence, and some 11 FAQs. So classification of this, we know that classification is important part. But let's go to the ASHRAE guidelines, which came in year 2022, a very important one. And here you have to focus on chapter 3. Chapter 3 is covering the recommendations, and this is what I've told you. There are chapter 3 talks only about fertility, and chapter 1, this is what you have to read as if you want to know about fertility issues. So, bird's eye view is that endometriosis is pretty common and it affects nearly every part of the pelvis. I think we all know about it, we are all maturing, but I think when it affects the ovary, then we have the maximum damage. Um Endometriosis doesn't leads to hydrosalpinx commonly until it's got an external pressure. It doesn't affect the tubes per se. It may compress the tubes. It can be affecting the bowel. It can be deep infiltrating. It can be superficial implants, which can occur here and there. So that's the way they work. And the commonest site we see is the ovaries. Then we have got cul-de-sac, uh, posterior broad ligament, then posterior cul-de-sac, uterosacral ligament. But ovaries are the common things. Just keep that in mind that ovaries are the commonest site of endometriosis. Which is the worst type of endometriosis? Who will tell me? The worst type of endometriosis, which really
Oval
scares me.
Where there is
endometriosis.
frozen pelvis, sir.
Rectosigmoid.
Deep
Rectosigmoid
infiltrating
endometriosis.
endometriosis.
Frozen
Endometriosis.
pelvis, which causes
Rec-
frozen
It
pores.
is adenomyosis.
Deep
Rectosigmoid.
infiltrating and
It is adenomyosis. Deep infiltrating, I won't bother. Actually, I won't bother in infertility. The only thing which troubles me is adenomyosis. Okay, I have opened the hornet's nest. I like to hear from any one of you. Why adenomyosis is so dangerous? I can see Ilamati, I can see Pranali,
Hello, sir. Good
Gabriela.
evening.
How are you?
Hello, sir.
Pranali, you are from our batch, Pranali? You're from our batch? You are our alumni or
Sir,
first time?
I joined last PCOS curtain raiser first time,
Correct.
and this is my
Okay, fine.
second time.
Second time.
Yeah,
Good.
yeah.
Deblina, how are you?
Yes, fine,
So,
sir. Thank you.
anyone would like to say something? Veena is there. Anyone like to say something? I said that adenomyosis is one dangerous thing, worst thing for us. Why so?
Because
Because
it
implantation becomes
disruption of
difficult, sir.
endomyometrial
Disrupts the
directly affects
endomyometrial
pregnancy.
junction.
It
Implantation.
causes myometrial contraction.
Endomyometrial
Super,
junction is affected, sir.
super,
EMJ.
super. We all know what is right. Excellent. I'm so happy for this. So that 1 in 10 women
Alters
are affected.
receptivity also, sir.
Excellent, excellent. Very, very good point again. Excellent. I don't know who said that, but who said that? It affects the receptivity.
Receptivity will be interrupted.
Super है.
Myself, sir, Dr.
iPhone,
Rao.
iPhone. नाम लिख लो अपना. I want to compliment you. Thank you so much, madam. Thank you so much. Thank you so much. So I think 10% of the people are affected, which are in the common population, and around 40-50% who are having infertility, they have endometriosis. And they are cause of 71 to 80% of all pelvic pains. This is some numbers given over here. But this picture is pretty interesting. I've just copied from somewhere that it has got 8 to 10 years of wait time before we can diagnose it. Guys, like a CS cervix and like a breast cancer, it takes around 8 to 10 years before getting Spotify. That's the beauty of this thing. It doesn't, we just can't diagnose it immediately. It takes a long time. And then there are four stages of endometriosis. Then I'll come to all these things again. But this is an important slide which covers that 176 million women. No, it must be around 180 million. This slide is around 2 years old. This I created today, and you see 10 to 15% of women are having endometriosis. This is for India. 30 to 50% are having infertility, and 70% are having pelvic pain. These numbers remind you of something else? Any other condition which mimics the same numbers?
Tuberculosis, genital tuberculosis.
No, no,
Tuberculosis.
Pooja, it is
Pelvic
PCOS.
inflammatory.
PCOS.
PCOS.
So
PCOS.
Exactly. Same numbers are
PCOD.
for PCOS. 10%, 50%. Just remember, because you people may have to speak somewhere, know what the percentages are. 10, 50. Always 10, 50 wherever you go.
So my
Great.
PG has PCOS along with that adenomyosis and endometriosis. So she has suffered a lot. And finally she conceived. She has a baby now, 3 year old. Yeah.
Wow, 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 wow. Fantastic, fantastic, fantastic. Great. This is how is the pathogenesis occurring? This is retrograde menstruation, which occurs here, and the reflux of menstrual tissue occurs, implantation. They survive. Actually, they survive. Every woman will have some amount of retrograde menstruation, but they don't survive. But here they start surviving. And how do they survive? Survive, there can be some immunological factors because NK cells are not there. Probably they're not working properly. It can be genetic predisposition, or it can be stem cell metaplasia, acidomic metaplasia. And then it can spread also. It can have lymphatic spread, hematogenous spread, or it can be iatrogenic spread. So, guys, I am halting here for you to just see this slide once. If you get time, you have time. Spend around 30 seconds on this slide. Just go through three compartments of it. It'll give you a lot of insight about how endometriosis originates, why it implants in some, and why it doesn't implant in others. The cavity is open, but they don't implant in everyone. And what other methods they can spread? It is hematogenous or lymphatic. So this is very well brought out by this picture. And now coming to the retrograde menstruation, it's a backward flow which will occur like this, which will occur like this, and there can be implantation and growth ectopic lesions can occur. These few things can occur here. So moving forward, we have to know that the endometrial receptivity goes bad, and here for implantation we need a good endometrial lining, and here we are having a bad endometrial lining. There can be adenomyosis or there can be progesterone resistance, altered gene expression, chronic inflammation, immune dysfunction, and discipline. So they want implant here. This is typical of endometriosis, that they've got a lower success and lower fertility rates. Done. I'm done till here. Now coming to when the girl looked at herself in the beginning as she went to a doctor's OPD, she saw that there are additions, there are ovulatory dysfunction. It can occur in endometriosis. It can lead to infertility. There can be chronic inflammation. There can be chronic implantation failure, and the receptivity goes off. So all these things finally will lead to poor outcome. And then we also know that these women very commonly have poor ovarian response. They are poor ovarian responders after some time. So all the things you have to keep in your mind, that the tubes directly here are not affected, but the tubes are blocked by the addition. This is what happens here more commonly. Coming to the diagnosis is very clear. These are the common symptoms we have discussed around 70% can have chronic pain, they can have dysmenorrhea, they can have infertility, which is a small part of it, which is not painful, but infertility is a separate part of it. And how do we diagnose it? Very beautifully given that it takes around 8.3 years. It takes 8.3 years before we are able to diagnose it. So laparoscopic visualization is always there, and this was taken as a gold standard, actually. Yes, this was taken as gold standard some time back. And then there are typical clinical features, MRI, ultrasound can be done. Anyone would like to say something about it? I made
Sir,
a blanket.
sir, today
So,
ultrasound can also diagnose it very well.
Good, Devlina. Fantastic. So laparoscopic is gone. It's no longer the
Proper,
gold standard.
properly done
Quality.
ultrasound is best.
Sir,
Excellent. Excellent.
sir, can I say something?
Bolo, bolo.
Sir, I have the another patient which is having like PCOS since 8 to 10 years. She was treated for PCOS and she is like ki reversible इसमें she is having no complaints menstrual irregularity का regulation हो गया था. She has two children and after 9 to 10 years she again came back with the sonography as having mild adenomyosis changes have started. So actual time taking process it was like ki 8 to 9 years. Means previously, it was very good environment of uterus, and now last year, since 2 years, she was having bulkiness, lower abdominal pain, and some heavy bleeding, and she got like tired and fatigue, extra associated symptoms. So again, we have treated her. Symptomatically, she is good, and somewhat changes occurred. The sonography, same radiologist has given the adenomyotic changes has disappeared. Is it so? It can it go proper
No,
totally? I
it
think
doesn't
no.
go. It doesn't. It doesn't go. It was a
Yeah,
wrong
that's why.
ultrasound.
That's why I have a question. How it is possible if it is anatomical and the
3D.
muscular? Yeah.
Only 3D can diagnose it. No,
Yes.
nothing. 2D
Yes.
can't diagnose
Yes.
it.
Yes, sir. Thank you.
Good. So it's ultrasound, MRI, laparoscopy. So I think so. MRI we don't do in our country. For me, my ultrasound is the best thing. My probe is the best thing I have, and it's a chronic disease. So I know it's a chronic disease, and it takes some time uh, to manage it. And now coming to treatment options and guidelines, relieve pain, slow the growth of endometriotic tissue, improve fertility, prevent disease recurrence. So I think we are focused here only. We don't talk about this, and this, though we'll talk about it, but this is not